Good afternoon, viewers. Once again, this is part 2 of our series this month on the micronutrient test and cardiometabolic. And last week, if you happen to miss it, that particular webinar, I discussed the various parts of the micronutrient test and, once again, how this test is performed. This week, we're going to talk about the cardiometabolic panel that SpectraCell offers, and I'm going to correlate this particular panel with the micronutrient panel. And I just want to emphasize this, that whatever test you perform with SpectraCell, whether it's the cardiometabolic, whether it's the telomere, if it's the MTHFR, any of those particular tests, you should always perform the micronutrient test with it. And hopefully today, when I start to connect some of these particular tests, you will see why it is essential that we always start with the micronutrient test and we build on that particular test, because it specifically correlates to what we're trying to achieve with the patient, and that is to customize our therapy for each patient's biochemistry. So continuing that, I just want to once again reiterate that the micronutrient test is based off of the lymphocyte. And once again, the reason why Dr. Shive picked this particular cell was because it's a long-lasting cell. It has a lifespan of about 6 to 9 months, and so you get a long-term effect. Now, the cardiometabolic is not based on this particular technology, but once again, as I mentioned, we always want to correlate the micronutrient test with the cardiometabolic. So I'm going to once again go over some of the previous points that we talked about last week and correlate them with today's webinar. As you know, that a person's nutritional status is based on numerous things, and this is just a short list of things that we have to consider when we are really evaluating a patient's health, whether it's their past medical history, their present medical history, if they've been on any prescription medication or over-the-counter medication, or how long they've been on that medication. Of course, do they have any specific dietary restrictions or habits that they follow? For example, as you all know, the paleo diet is very common now. The gluten-free diet is another dietary regimen that a lot of people are following. And once again, we'll talk about how that correlates to today's testing. Exercise, is it light exercise, heavy exercise? Does the person exercise 2 days a week, or does this person exercise 5 to 6 days a week or more? Stress, is it psychological stress on this person, or is there physical stress like heavy exercise? People that are training for marathons, triathlons, people that are getting involved with CrossFit now, those particular individuals that are exercising at a high intensity like that definitely have an impact on their nutritional status and also on their cardiometabolic status, which we'll talk about. Sleep, are they getting 5 hours of sleep a day, or do they need 10 to really recover? Genetics, we always, of course, have to consider genetics. And, of course, as you all know, this is a very hot topic today. So, once again, 2 people can take the same amount of vitamin D and have different uptake, different utilization, and part of it may be due to the vitamin D receptor. And so we know that's just one example of this particular situation. The nutrient-nutrient interactions. Once again, does a person take a particular vitamin, mineral, or metabolite that may be interfering with another one? And we'll talk about some of that today, is how you may be prescribing a particular nutrient for somebody, but at the same time that particular person needs that nutrient, and it will interfere or cause some problems down the road if the dosage is not balanced out. And then, of course, the overall uptake, digestion / absorption of an individual. Do they have something like irritable bowel syndrome? Do they have constipation? Do they have some other GI situation where maybe part of their GI tract was removed? Maybe they had gastric bypass surgery, and that's going to once again affect certain nutrients as well. So we have a lot to take into consideration, as you can see. And so when a person is deficient in a particular nutrient or nutrients, that you have to go back and say, what do you think the causes of this particular individual's deficiencies? Now, if you look at this first report, this once again is from last week, and as I mentioned, this particular person is having issues with their glucose/insulin. In fact, this person mentioned that their HbA1c is starting to climb a little bit, and so they want to do this test and see if there are any direct measurements with this. And the cardiometabolic will help pick that out, as you will see in a few slides here. But the point is, what is causing that person's glucose or HbA1c to go up, or what is causing that person's cholesterol or triglycerides to go up? You know, a lot of people will have high triglycerides and they'll say, cut out your fat in your diet, watch your simple carbohydrates, and take some fish oils. Well, all three of those things may be beneficial, but the question is, are you really getting to the root of the problem? Are you really working on the nutritional deficiencies that are causing that triglyceride elevation or the glucose elevation, or even the HbA1c elevation? So once again, this is a micronutrient test that you always want to perform whenever you are doing another testing with SpectraCell. Then there is a part where we talked about the SpectraCell and Immunodex, and of course this comes into play with cardiometabolic, because if a person does have a high cholesterol level or high triglyceride level, is that going to predispose that person to atherosclerosis or arteriosclerosis? And of course, do we need a certain amount of antioxidants to cover that lipid peroxidation that may be going on in the vasculature? So once again, the SpectraCell is giving us that indication that this person is subpar or suboptimal with their antioxidants. So they would be more prone to have lipid peroxidation at a very high rate and more likely have a better chance of atherosclerosis and eventually arteriosclerosis down the road. The Immunodex, once again, is a measurement of the first 5 days of growth of the media, which I showed in last week's webinar. But it also correlates with certain nutrients like vitamin C, selenium, copper, and so on. And those are related to the cardiometabolic, which I'll correlate today. So if you are new to SpectraCell, once again, these are some of the graphs that you will see, or typical graphs that you will see on the micronutrient test. Of course, the white is adequate, the yellow is borderline, and the blue is considered deficient. And once again, you want the person's squares at least in the mid-white of each graph, and if it hits the yellow, it turns black, and of course, if it hits the blue, it turns red. And so on this page, you will see that there are several red squares on the bottom of this page. And those particular red squares include, of course, vitamin D, vitamin A, calcium, zinc, copper, and magnesium. Then you see on the row above that, the oleic acid, which is in the blue. And for those of you that missed the webinar last week, that oleic acid plays a very strong role in the bottom row, that you have to correct that oleic acid. Now, that oleic acid is also going to play a role in today's talk with the cardiometabolic. As you know, the Mediterranean diet has the strongest support for prevention against cardiovascular disease. And since that is our main topic today, you definitely would want to correct that oleic acid. And once again, the Mediterranean diet, as you know, is high in oleic acid. So it's one of the nutrients or products we know that's found in the Mediterranean diet that helps fight cardiovascular disease. So this micronutrient test is telling us that this person has to consume more of this product, whether it's through supplementation or whether it is through dietary changes such as olive oil and avocados and walnuts and almonds and so on. And the point is, though, you're customizing, you're finding out that this particular person has this connection. Now, once again, that oleic acid has to be corrected in order to correct the row where it says other vitamins and minerals. This next row, of course, this is a breakout of the top row, and of course the BComplex Vitamins, and this is something that we want to look at as well. We want to see if any of these particular vitamins are deficient. And the reason why we would want to do that with cardiovascular disease is because the B6, the folate, the B12, and the B2 all have a role in lowering homocysteine levels. And that is something that we look at on the cardiometabolic panel. And once again, I'll try to correlate that or point that out to you once we get to that particular section. Now, once again, this section, as I mentioned, this is the one that contained the oleic acid, and you can see that oleic acid is clearly deficient at this particular point, where the asparagine is borderline. Asparagine really doesn't have a large role to play with cardiovascular disease. It does have some role to play with the immune system, but not a strong role, once again, with cardiovascular disease. But you still would want to consider this particular nutrient, even though you are maybe looking solely at the cardiometabolic panel in your patient. Now, before I get into the cardiometabolic panel, I want to show you some evidence on why we are looking at this. As I mentioned, the cardiometabolic panel will not only look at the cholesterol, triglycerides, and different particle sizes, but it will also look at measurements that are associated with diabetes. And as you look back on the previous slides, you will see that this particular individual had a deficiency of vitamin D. And here's a piece of literature that confirmed that vitamin D that has the particular relationship. So once again, the point is that you have to look at the dosage of vitamin D if a patient is taking the taking vitamin D. Are they taking the adequate dosage? And you have to change the dosage, and are there any other nutrients that are associated with that? Well, once again, you can see here that they show that vitamin D not only affects the insulin synthesis, but also secretion and possibly the insulin receptor. So as a result, there's 3 possible mechanisms on vitamin D and the role with diabetes. And once again, this person had a vitamin D deficiency, and we will show you the cardiometabolic and once again how that correlates. Another nutrient that's talked about a lot, and I mentioned this I think last week, is that magnesium has over 300 functions in the body. And if there's only one nutrient that I could really carry in my particular practice, this would be the nutrient that I would really push. And it has so many functions, but also so many things that we do every day in our life affects this, whether we're under stress, whether we consume alcohol, caffeine, or some prescription medication that works as a diuretic. And you can see here that magnesium definitely affects insulin resistance as well. And you'll see that there's also a role with magnesium in the lipid control. So this person, once again, had a magnesium deficiency, and once again, we're going to correlate how that magnesium deficiency along with the vitamin D deficiency actually is affecting this person's cardiometabolic panel. And once again, it's a combination. Now, magnesium is responsible for hydroxylating the vitamin D, and vitamin D enhances on the uptake of magnesium. So they both have a very synergistic role with one another. So this is why we would not just want to test vitamin D, and there's a lot of clinicians out there, and you may be one of them, that actually is just testing for vitamin D and wanting to see if a person has a vitamin D deficiency. But what's really important is we understand that the vitamin D is going to play a role with magnesium. And we know also that vitamin D plays a role with vitamin K. And we also know the role, of course, with vitamin D and calcium. So the point is that we have these different relationships. Now, there's not a ratio that goes with magnesium and vitamin D, but once again, you should always consider them together. Another nutrient that has been very thoroughly looked into in the role of diabetes is zinc. And once again, you can see here's some information from different citations regarding the role of zinc in diabetes. And if you remember that in this particular patient, they had an abnormal SpectraCell and they had an abnormal Immunodex. And as you know, zinc works as an antioxidant and also works with the immune system. So this particular nutrient not only plays a role with diabetes, and you will see also plays a role with cardiovascular disease, but it also plays a role with the overall antioxidant status of the individual and their immune system. So once again, a nutrient that we look at very closely. Now, this one is associated with copper. Whenever you consider zinc supplementation, you always want to consider copper supplementation. Now, depending upon who you read, usually we look at a zinc to copper ratio about 10 to 1. And sometimes if the copper is really good on a patient and zinc is low on this test, then we might go a 15 to 1 ratio. But if we go higher than a 15 to 1 ratio, we have a tendency to cause a deficiency of copper. And copper deficiency has been associated with elevated cholesterol levels. So once again, that we have to be careful on what we're giving and when we're giving it, the dosages and the ratio if they're applicable to one another. So you can see in this case that vitamin D has been associated with diabetes, zinc, and magnesium. And once again, I'm going to tie this all together in a few minutes with the cardiometabolic panel. Now, this is the row I was talking about that has the vitamin D all the way across to the magnesium. Now, you can see in this case that this person does have a copper deficiency. And so when we give zinc, we want to give copper to keep it in a certain ratio, but also to correct in this aspect. So you can see manganese and where that particular person's square is. And it'd be nice to get all of those squares of this patient's results up to the mid-white or higher. Now, vitamin A is not strongly correlated with cardiovascular disease, but it is strongly correlated with zinc. And so one of the things I want to point out is when you're looking at zinc, you also want to look at vitamin A. You don't look at this from a ratio standpoint, but zinc actually complements vitamin A. So when you correct the zinc, if the person's consuming an adequate amount of fruits and vegetables in their diet, they should be able to correct the vitamin A if you correct the zinc. So that's the correlation in that aspect. And once again, I mentioned that also in last week's webinar. Now, this is a glucose-insulin interaction. So now we're going to get into the diabetic portion of the cardiometabolic panel. And you can see that this person definitely has an abnormal glucose-insulin interaction, which is indicating to us that she is having some problems with insulin receptors, or it could be even insulin production. The point is, I showed you some research out there that confirms that zinc, vitamin D, and magnesium are correlated with this. And then I showed you her micronutrient test that further confirm that those nutrient deficiencies could be associated with this. So what's nice about this example today and how I'm tying in the micronutrient test with the cardiometabolic is that we are finding out specific nutritional deficiencies. We are getting to the root of the problem to see what deficiencies are actually causing this person's glucose insulin. She could go out and have purchased a product that was maybe high in chromium and high in vanadium sulfate. And both of them we know helps with glucose and helps with insulin receptors. But the point is, you can see right here in this example that she doesn't have an abnormal chromium. So you could actually push this person into a chromium supplementation without prior testing, and she might not improve her HbA1c or her serum glucose. And you say, you know what, I've read articles that chromium should help HbA1c, it should help glucose levels, and it didn't help this person at all. The reason why is because this person doesn't need any more chromium. Yes, we could improve it a little bit, but the point is that she should have enough chromium to actually affect her insulin receptors. And if that was the cause of the glucose-insulin interaction, then the glucose-insulin interaction would once again be normal because the chromium is normal, but it is not abnormal. The chromium is not abnormal, so as a result, that's not the cause of the glucose-insulin interaction. We already found out 3 nutrients in this patient that are probably the etiology of this problem, and that's vitamin D, zinc, and magnesium. Now, another nutrient that is associated with diabetes is CoQ10. And you can see here that one of the things that they have found is that CoQ10 is beneficial for individuals taking statins. And as we all know, whether a person is type 1 diabetic or type 2 diabetic, that these individuals usually have cholesterol or triglyceride problems, and as a result, are usually on a statin. And if they're on a statin, they have a good chance of having CoQ10 problems. And you can see by this particular documentation that CoQ10 can definitely improve endothelial dysfunction that's caused by, once again, abnormal cholesterol in these individuals, and can affect the overall oxidative stress of this individual and accelerate atherosclerosis or arteriosclerosis. Once again, you will see with this particular person has a correlation with CoQ10 and the glucose as well as cholesterol issues. Now, this is another part of the micronutrient test, and I just talked about the CoQ10 relationship and diabetes. And if you look at this individual, you'll see that she has a borderline value for glutathione, a borderline value for CoQ10, and a borderline value for vitamin C. So we talked about the CoQ10 and diabetes. We talked about the CoQ10 and oxidative stress and possibly the atherosclerosis and arteriosclerosis. So once again, you can see this, how this is a great example of how we are looking at the micronutrient test and how we're going to tie it into diabetes and cardiovascular disease. Now the point is, if you did not do the micronutrient test, and I'm going to show you the cardiometabolic test, and that's all you did, you will be guessing. You would actually be guessing on what to do for that patient, because I'm going to give you some different scenarios when we get to the cardiometabolic and show you how people are guessing today on therapy for their patients rather than customizing their therapy. Now, once again, you can see that this person has the abnormal SpectraCell that I talked about earlier, and I'm going to jump ahead a little bit here, go through these slides quickly because we've already showed you earlier. Evidence of this in the Immunodex was also borderline, and as I mentioned, this is where the zinc comes into play, as well as vitamin D with this individual. Now, this is just a summation of some of those previous slides, but once again, think about this. The glucose-insulin interaction is abnormal. The glutathione, which we know can affect oxidative stress, the CoQ10 the same, and vitamin C the same. So now, this is a summation of the person's micronutrient test. And once again, this was talked about last week, and so I'm going to skip over this, and if you want to know more about that particular person's micronutrient test, you can refer to the webinar that was performed last week. So now I'm going to get into the main topic today of the cardiometabolic test. And as you can see in this particular testing, that not only does SpectraCell do the typical lipid panel, which is actually noted in the middle of the page here, but it also looks at the particle numbers, which clearly differentiates itself from other labs out there as far as specificity and how important this is, because the lipidemiologists out there are highly talking about the lipid particles. And then to further complement the top and middle portion is, you can see SpectraCell also looks at what they call the vascular inflammation and biomarkers. And we're going to talk about these, but how we're going to talk about these is how they correlate with today's literature and the micronutrient test that I talked about last week, and would tie in today with this particular panel. So here's a good example. As you noted on the previous slides, I talked about low magnesium and diabetes. And now here's a situation on magnesium and hyperlipidemia. And you can see that this was published in South Medical Journal in 2001 in December of that year. And once again, as I mentioned earlier, that magnesium has over 300 functions in the body, enzymatic functions. And for this reason, it has a role in more or less every system in the body. The point is that we are doing some things to patients that are helping them in one aspect but affecting them in another aspect. And let me give you an example of what I mean by that. A lot of people that are diabetic also have cholesterol problems, but also have hypertension. And if they have hypertension and somebody prescribes them a diuretic, especially one that is a non-potassium sparing diuretic like hydrochlorothiazide, which will actually cause potassium loss and magnesium loss, that you could have a person that has hypertension and diabetes but has a normal lipid panel. But as you give them this diuretic, that it will eventually cause a magnesium deficiency, and the magnesium deficiency will now cause an elevation in cholesterol and or triglycerides. So now what are you going to do? You have a person that was diabetic, hypertensive, did not have cholesterol or triglyceride problems, but now has cholesterol and triglyceride problems. And so, of course, one of the common things that most clinicians say is, oh, you must have a hereditary factor involved because your mother has cholesterol, triglycerides, or your father had elevated lipids, or maybe your grandparents. Well, that may be the case in some cases, but in this case, the scenario I just gave you is that person took a medication that has diuretic effects and actually caused a magnesium deficiency. And that's what caused this particular problem of elevated lipids. Now, if you are the clinician that is still testing serum magnesium, you are not testing a very sensitive marker. And that's the point, is only approximately 1% of total magnesium in the body is found in the serum. And so you're looking at a very, very low percentage or amount of magnesium. And that's why a lot of serum magnesium levels are normal in these individuals. And a lot of clinicians will say, oh, you don't have a magnesium problem. The magnesium is not causing your elevated cholesterol, triglycerides. And then they kind of push that topic aside. When the case with SpectraCell, they do a micronutrient test. We're looking at intracellular, which has a much higher percentage of magnesium than the serum or plasma does. And now you're getting a true test. And I showed you that on this person, that she has an abnormal magnesium. And once again, she has some abnormal findings on her cardiometabolic. And this is a good example. As you can see, if a person has a normal value on this particular type of graph or presentation, their numbers will be highlighted in green. If they have a borderline value, it will be highlighted in yellow. And, of course, if they have an abnormal one that's more severe than borderline, then they are outlined in red. And so you can see on this particular page that this person has a total LDL particle that's elevated. They have a total HDL particle that's borderline low, the non-HDL particles that are borderline low, and then the dense LDL4, which are, once again, abnormal. They should be less than 100, and this particular person is at 131. Then if you look right below that, you will see that the typical lipid panel that most everybody, including myself, was trained on when we were first trained on laboratory diagnostics, you can see that she has an elevated cholesterol 206. Her LDL is borderline, just like her cholesterol is, and then she has some good markers with the triglycerides, HDL, and non-HDL numbers, but once again, the particle numbers are different. Then if you go into the vascular and inflammation portion, along with the biomarkers, now you see an elevation of the CRP, high sensitivity. And she is almost 2 times normal. She's at 5.9. And then you see that the apolipoprotein B is borderline. Now, this is a marker of hereditary. So she does have some hereditary component here, and that's what the apolipoprotein B more or less tells us. But the CRP, HS, once again, as we all know, is an inflammatory marker. Think about this. Before I even started talking about the micronutrient test, if I just showed you the cardiometabolic test, and you were looking at this test, and I said to you, what would you do, just this portion of the test, what would you do for this person? I would bet that the majority of you out there would probably say I would give this person omega-3s, because omega-3s have an anti-inflammatory effect. They have been shown to be beneficial for cardiovascular disease, and I would agree with you. But if you think back of the micronutrient test and how it ties into this test, now there are a lot more things that we have to think about. We have to think about the magnesium. We have to think about the vitamin C. We have to think about, once again, the zinc, once again, because that has an anti-inflammatory effect as well. We have vitamin D that has, as we know, antioxidant capabilities. And so all of those now come into play with this particular individual. So you may correct this CRP with omega-3s, but are you really getting to the root of the problem? Are you directing your therapy to every possible nutrient that may be deficient or borderline that's causing this elevation of the CRP? And like I mentioned, before I used SpectraCell, which was 25 years ago, I would attack this with the omega-3s, just like probably 99% of us out there. But the point is, now we have further diagnostics and confirmation based on the literature and based on this example on how the micronutrient test is essential to tie it in with the cardiometabolic test. And this is just one example. I'm going to show you some other examples here in a second. But the point is that it is very, very important that you do that. And as you know, I do some consulting for SpectraCell, and there's times where I'll talk to a doctor or a dietitian, and when I'm talking to them, all they've ordered is a cardiometabolic test. And they'll say, well, what would you suggest that I do with this patient, Ron? Well, once again, you can imagine what my answer is now. You can try some omega-3s, but you're not getting to the root of the problem unless you pull a micronutrient test with it. And that's what you'd have to do, is go back and pull a micronutrient test to further confirm what you're doing on a very customized level. So here's an example. As I mentioned earlier, we talked about magnesium and its role with diabetes. We talked about magnesium and its role with hyperlipidemia. Now here's another citation showing how, through the American Journal of Clinical Nutrition 2006, how magnesium also affects the CRP. So this goes back to that previous slide. Here the person has an elevated CRP, and we confirmed through the micronutrient test that the micronutrient test, she had a deficient magnesium. So you can see that this particular person, it correlates so well with the literature and how one nutrient, magnesium, can affect her CRP, can affect her cholesterol, can affect her insulin or HbA1c. And so with one nutrient, you're going to, once again, attack several of the things, and we're confirming it with these two testing modules or panels, the micronutrient test and the cardiometabolic panel. Now, as I mentioned, there's numerous things that we have to look at, or we have to consider magnesium for when we're looking at the patient. And you can see that magnesium is a calcium channel blocker. So this is one of the ways it works for hypertension. It modulates lipid metabolism. So this is how, of course, it affects or modulates our triglycerides and our cholesterol. Stress depletes this nutrient. Once again, physical stress like exercise or psychological stress. So any of us that suffer with stress on a daily basis or weekly basis, we're going to have a higher demand of magnesium. Caffeine depletes this nutrient. Diuretics deplete this nutrient. As I mentioned in last week, and once again today, is there's often a saying in physiology and biochemistry that where potassium goes, magnesium follows. Because as you know, they're primarily intracellular nutrients. And as a result, those nutrients have a tendency to leave the cell when one or the other is affected. So potassium leaves, we often see magnesium leave, and vice versa. So the point is that if a person is consuming a food item that's a diuretic, could be coffee, could be tea, could be alcohol, or they're taking, once again, a prescription medication. That's a diuretic, as I mentioned earlier. We're going to affect the magnesium, and now we're going to affect their HbA1c, we're going to affect their glucose levels, we're going to affect their triglycerides, their cholesterol levels, and we're going to affect an inflammatory marker called the CRP. So taking that into consideration, this once again is a indicator of those previous numbers. And these boxes are just shrunken down to show you that they were pulled from the previous panel, and then they put this graph above that. The graph above it is a culmination of these numbers. So if you look at the left lower corner where my arrow is pointing, that is indicating your triglycerides. Your middle peak here is indicating your LDL. It could be your LDL1 and LDL2, which are to the left of that dotted line, or it could be the LDL3 and LDL4, which are to the right of that dotted line. And then this particular peak here is actually representative of your HDL. And you can see that this person has a very good HDL result or accumulation. The nice thing is that her HDL-2B is the one that's primarily going to throw that peak to a higher level there, and that's the protective type, or that's the one we're really looking at. As you know, or maybe you don't know, but there are three HDL. There's HDL-2A, 2B, and 3. And it's the HDL-2B that we really want to be elevated. And so for that reason, if you're doing the standard lipid panel of just cholesterol, triglycerides, HDL, LDL, and maybe CRP, you are not getting the true picture of the HDL if it's elevated. It may be the majority of that HDL may be 2A or maybe 3, which we really want it to be 2B. So once again, it's through this particular testing that actually breaks it down into those different subsets and shows it in this graph. Now, as you can see, if this person's LDLs were high in the form of 3 and 4 primarily, that this peak would be to the right of that dotted line. And this is why this pink here goes down a little further than on the left side of that dotted line. And the reason is because if you have a higher amount of LDL3, dense LDL3 and dense LDL4, research shows that you have a higher incidence of atherosclerosis and arteriosclerosis. And so if we're going to have an elevated peak there, we definitely want our patient to be to the left of that dotted line versus to the right side of that dotted line. But if they are to the right side of the dotted line, my advice to you is become very aggressive with this person in regards to therapy and try to lower that as fast as you can, because they're at a much higher risk than individuals that are to the left of that dotted line. And once again, we'll talk about some of the therapeutic approaches for that. Now, once again, this is a breakdown, just a blow up of this one so you could see it a little easier, because that other page or slide was a little bit, like I said, there's a lot of information on there and not confusing, but once again, hard to see at this level. So you can see here the VLDL is representative. That is the lipoprotein that is highest in triglycerides. Then you can see there's a part here that says IDL, and this stands for intermediate dense lipoprotein, or now some people refer to as RLP, as remnant lipoprotein. And then, once again, it's a risk factor, and that's why you can see that this pink comes down here pretty rapidly. Then we go over the LDL1, 2, and then the 3 and the 4, and then here's your HDL2B, your 2A, and your 3. So if this particular portion was really high here, that's not as protective as here. So you can see from this line to this line that there's major peak, and that's your HDL2B, which is, once again, very protective of this patient. So this is the bottom portion of that one box that I was showing you. And once again, this is the part that breaks this out. And you can see the ones highlighted in red, of course, are the ones that are significantly elevated. The ones that are in yellow are borderline elevated, as it states over here on the right-hand side. Now, the total HDL is a little different. This is the one that you want it to be elevated, because this is your protective particles, as you know, and you can see that this is 7,754, and we want it to be greater than 7,000, so this person's considered to have a borderline value for the total HDL particles. Now, below that is where you will see that the person has a large buoyant HDL2B. So this is the more protective of the HDLs, and we want it to be greater than 1,500, and this particular patient is over 2,700. So it's a very good level. So even though the total HDL particles are not as high as we want, out of that number, there's a large portion that is HDL2B, which is the protective type. Then, of course, the panel below that you will see is the total cholesterol and LDL, so this is what most of us are trained on. And then the middle panel, of course, is pointing out that C-reactive protein that was elevated on some of the previous slides, and how we mentioned that magnesium definitely affects that. Now when you're looking at the diabetic portion of this particular panel, you will see that this individual has a hemoglobin A1C that is borderline, that this particular person has a 5.6, and we want it to be less than 5.6. So it's highlighted in yellow. Now, if you think back about the micronutrient test and the correlation with this person, is that there is a magnesium correlation with the HbA1c, there's a vitamin D correlation, and there's a zinc correlation. This person did not have a correlation with chromium. So if you have a tendency to just supplement every one of your diabetics with chromium, you may be giving them a product that they may not need or they may not really show benefit to. And this is why we have to be careful sometimes about reading the literature, because out there somebody might have done some research on chromium and diabetes. And if the people that they looked at did not look at intracellular chromium and did not look at these different connections, they could have said, these people are diabetic, we supplemented them with chromium, and we didn't see this significant amount of benefit, so chromium has no correlation with diabetes. No, that is bad research, because they did not look at first to see if these people really had an adequate amount of chromium intracellular-wise versus serum-wise to see if there was a correlation with that. And did they look at all these other nutrients that we did on the micronutrient test to say, yes, there is a correlation with vitamin D, magnesium, zinc, but this person did not have a correlation with, once again, chromium. So once again, this is just blown up portion, so you can see it a little better than on that previous slide, but you can see based on this that this person has a low risk because their HbA1c is, once again, it's borderline, but their insulin is very good. Their glucose is, in some cases, people say high normal because, as you know, a lot of labs will have a value of serum glucose of 65 to 99. In this particular case, SpectraCell uses 70 to 105. But then, once again, the CRP is 5.9. And so it's a strong inflammatory marker, but there is a portion of, once again, that we look at all of these results to give us either low, moderate, or high risk. But this is not, even though this is a low risk, it doesn't mean that you should take this lightly, that you should still attack these and try to lower these as quickly as possible. Now, this is what we call the omega check, and the omega check breaks down your omega-6 and your omega-3. And as I mentioned, we already know that this person has an elevated CRP, and this would be the case where you could give them omega-3s and see some benefit with their CRP. And it makes a lot of sense because you can see in this particular individual that the omega-3 total is actually telling us that the EPA, the DPA, and the DHA are all low. And when you add all of these up, these three together, that will give you a value of 3.9. And you can see when we add these three together, we want to have a value greater than 5.5. But what's also important about this is the omega-6 to omega-3 ratio. And of course, if a person's consuming a lot of omega-6s, and of course, omega-6s are high in chips and crackers and cookies and things like that, that they're going to have a high omega-6, which you know are more inflammatory, versus omega-3, which are more anti-inflammatory. So by saying that, you can see that the omega-6 to omega-3 ratio is high, which would more or less confirm that this person probably would have an elevated CRP. The arachidonic acid to EPA ratio is high, significantly high. We want less than 5, and this is 17.4. And then, of course, they split out the arachidonic acid and linoleic acid on the bottom here. And then they do a summary below that. So once again, you can see how this all correlates. And once again, this is a blown up slide of what I just showed you. And this is a portion of the cardiometabolic panel. So when you order the cardiometabolic panel, you can see you get some information regarding glucose regulation, whether it's HbA1c, serum glucose, insulin levels, adiponectin, and various products like that. You also get the omega-3 check, which is telling you the breakdown of the omega-3. If the person's taking omega-3, are they actually benefiting the person? You know, we shouldn't just assume that we give a person omega-3 and they're adequate. And then the cardio part of it, which is the lipoprotein particles. It gives you the standard lipid panel, then it breaks down the LDL particles and the HDL particles, and then we also get the inflammatory portion and biomarkers that tells us is there some inflammation going on at this particular point. As you look over this and maybe listen to this webinar in the future, hopefully you will see that there is a strong reason why I advocate that a person performs a micronutrient test with a cardiometabolic test. And in the next couple of weeks, we're going to talk about how we're correlating the micronutrient test with other tests that SpectraCell provides. And then in the following weeks and months, we'll talk about different pathologies, showing some correlations with that, connecting nutrients to that particular pathology, and showing you why, whether it's thyroid problems, whether it's obesity, whether it's cardiometabolic, whether it's diabetes, any of those, how the micronutrient test is your base test, and every other test out there should be performed with that micronutrient test so we can, once again, attack this person. And I think this is a very important word. Customize your therapy to that patient. Because I think all of us would agree that no two diabetics are biochemical identical. That we all have this individuality about us, and we need to all be treated as an individual person rather as a group saying, oh, you're diabetic, you all get this medication, or you all get this vitamin or mineral, or so on. Let's customize it. That's what should help your patients in the future. And now you have some objective means of really looking at this and saying, I know what nutrient you need, and in the follow-up testing, I know what nutrients I need to watch for. If I give you a particular one, as I mentioned, the magnesium and vitamin D correlation, the zinc and copper correlation. So it's very important. So for the next few minutes, I'll be happy to open it up for any questions that you may have and try to address the questions and how it relates to the micronutrient test and the cardiometabolic panel. Well, based on a little message I'm getting. There are no questions yet. Hopefully, like I said, if you do have questions, you can contact SpectraCell through either the representative, or you can, as you can see here, there's a phone number and an email address to contact and submit questions that you may have, or get a hold of a representative or a consultant that can maybe answer those questions. But I think it's very obvious today, and hopefully last week as well, on how nice these panels are correlating with the scientific literature. And I hear that all the time from doctors around the country that say, you know, Ron, the things that you told me about diabetes or cardiovascular disease or thyroid issues, I see that now on these tests, and it correlates with the literature that you've talked about or you cited. And that's a nice thing, is there's some brilliant people out there, researchers, that are finding out this information, and SpectraCell has, you know, produced these testing procedures to confirm what these researchers are saying out there. So once again, we're just waiting to see if there's any questions over the next few minutes. But I think you'll find these two panels, the micronutrient and the cardiometabolic panel, to be very useful in your practice, and once again, state of the art. We have to get away from some of our antiquated testing or things that are not very specific, that all of us that have been in practice a long time have used, and now we're advancing. Now we're going from the lipid panel to the lipoprotein particle panel to the cardiometabolic panel, and once again tying that in with specific nutrients. So I think it's very important that we continue this, and like I said, in the next couple months, we're going to take various topics / pathologies and correlate the literature with these panels and show you how common this really is. This example today is one of many, and when I go through the data and I go through various consulting times with doctors, I could pull out things like this on a regular basis. So I thank you for your time. Once again, I hope that this has been educational to you, and you will use these panels together and customize your therapy with your patients. Thank you.